Everyone to Geriatric Medicine Grand Rounds. Happy to have you all for our first Grand Rounds for the new academic year. We have 4 new Geriatric Medicine Fellows and 6 new Palliative Medicine Fellows, many of whom are probably also joining this session. So welcome to all of you. We did a little bit of a welcome at our conference last week, so many of you got a chance to hear a little bit about them, but you'll get to know them over the year. But our speaker today is familiar to almost all of you, I'm sure. It's Dr. Drew Hunter, who just graduated from our fellowship on June 30th, but here he is already giving a grand rounds. And I appreciate him rescheduling to this date that worked for everyone. He's going to talk to us about HIV in the older adult population. Thankfully, Dr. Drew Hunter is staying with UW Medicine, and he'll be based here at Harborview. And if you want to tell folks what you'll be doing, and go ahead and get started. Thanks so much for doing this today.
Yeah, thanks, Kate. I really appreciate the flexibility. So yeah, I'll be hanging out at Harborview, doing mostly hospital medicine and palliative care consults as well a little bit later in the year. And I'm presenting today on HIV in the older adult population. I have no disclosures to make, and if references aren't included on the slide, they're at the end of the presentation and we can go over them. The objectives for today, I'd like to provide a general overview of the epidemiology of HIV in persons living with HIV over the age of 50 years old, discuss some risk factors in the older adult population, review common challenges in screening and in diagnosis, review associated non-AIDS morbidity in this population, and take a look into some of the translational literature of aging and HIV. Before getting started, I think it's important to review the timeline of HIV, especially in the United States, and when AIDS was first discovered and how far we've come since then. So it was 1981 when the first cases of AIDS started getting reported in Morbidity and Mortality Weekly through the CDC. And it wasn't until 1987 when the first antiretroviral drug, AZT, was being used in wide scale. And then it wasn't until 1996 where we first started seeing, actual good efficacy of the antiretroviral therapy. 2012 was when we first saw PrEP, so pre-exposure prophylaxis, being rolled out. And now in the realm of the 2020s, we're starting to see that the lifespan of people with HIV is starting to very closely match the general population. But back in the 80s, it was a very different picture. This was a feature series out of San Francisco Chronicle from mid-2000s, where they took a look and interviewed some patients who had been diagnosed with HIV and AIDS earlier in the epidemic when it was a near-death sentence and prognosis wasn't, decades and decades, but really was months and potentially years, and explored the physical, psychological, and economic impacts of surviving that epidemic and that infection, from the 80s until now has had on people, where when you spoke with your physician, there was really nothing to be done aside from offering condolences. And this idea that you were living with what was supposed to be a death sentence over your head at that time. One of the striking things I had seen was that in the Bay Area Reporter, a prominent gay newspaper out of San Francisco, it wasn't until 1997 where they were first running a newspaper without any obituaries from HIV and AIDS related deaths. The data here from the San Francisco Department of Public Health is just to illustrate how profoundly different the landscape is now compared to then, where you see the years between 1986, 1987 until 1996, with such a high incidence and prevalence of AIDS diagnosis, but also AIDS related deaths. So taking a look now, we know that if someone has access to care, HIV is no longer a life-limiting infection. Not only do we have an increasing number of young people with HIV surviving, we also see an increasing number of older adults newly acquiring HIV. What this means is that the prevalence and incidence of HIV infections in those older than 50 years old is increasing at a faster rate than the population as a whole. So between 2015 and 2019, while the prevalence increased 8% in the general population, incidence of infections actually decreased 4%. However, in looking at the adult population over the age of 50, not only did prevalence increase 40%, but incidence also increased 15%. And it's felt that one of the main drivers of this is condomless sexual activity intragenerationally, as well as intergenerationally. So these are data from the CDC. This particular set is year-end 2018. I think there might be a slightly newer set, although there were some caveats with counting from COVID, et cetera. But the trends were very similar, that about half of the people living in the United States diagnosed with HIV are over the age of 50 years old. And it's the highest prevalence in any group is, as you can see, 50 to 54, followed by 50 to 59. And you can see here, looking at incidence of HIV infections, that about 17% of new infections are in persons over the age of 50 years old. And then taking a look at some global data, you can see here that those over the age of 50 in high income countries are represented by the blue bar on the bottom, and those in low and middle income countries by the orange bar at the top. Populations in both are growing. The prevalence is certainly growing at a higher rate in those living in low and middle income countries, which account for the vast majority of numbers of people living with HIV over the age of 50 years old. But looking at proportions, certainly in higher income countries where patients have access to better care and antiretroviral therapy, the proportion of people living with HIV over 50 is much higher. The CDC estimates that about 6 million people over the age of 50 in the world are living with HIV, and it's about 20% of the people who have the disease total. 80% of them live in low and middle income countries, but kind of as alluded to on this slide, a much higher percentage are in high income countries. And while they're living longer across all countries, they remain disproportionately burdened with multimorbidity, which is only exacerbated in some of the more resource poor settings. So we saw half of the people living in our country with HIV over the age of 50, yet they account for 70% of total deaths. Obviously, there's a higher prevalence of multimorbidity, which we'll get into in a little bit, but also there's a tremendous problem of late diagnosis, where about 35% of people diagnosed in this age group already had AIDS at the time of diagnosis. When we look at the causes of death for this group, with access to antiretroviral therapy, we're looking at cancer, cardiovascular disease, and neurocognitive impairments driving mortality. We're also seeing an increase in frailty-related syndromes and an increase in changes in physical function that impair quality of life. So risk factors for acquiring HIV in those greater than 50 years old. The number one risk factor is sexual exposure. Injection drug use is less common. For males, including those 50 years old, male-to-male sexual contact is most common in the United States, Europe, and Australia. And for females greater than 50 years old, the primary exposure is through heterosexual contact, with an increased risk in this age group due to vulvovaginal atrophy and a lower use of barrier contraception. So we know that more and more older adults are newly acquiring HIV, as well as more adults are aging into this group. We know at this point that the main risk factor for males and females remains sexual exposure. So I think it's important to address some of the challenges that we share in properly assessing and screening for HIV in this population. What we are seeing, especially in Western countries, is a different dating landscape. Older adults are continuing to have sex, which is something that we don't often talk about as providers. And we're seeing different ways where people can continue to date and express their sexual identities. And it presents challenges in assessing and screening from providers and patients' perspectives. The CDC estimates that only about a quarter of adults 50 years or older have been screened for HIV. And despite our perception, sexual activity is actually very common among older adults. This is actually something I discussed during the Jerry psych rounds earlier in the year. The New England Journal of Medicine did a survey of about 3,000 people in this group asking about sexual activity within the prior year. Almost 3/4 of those aged 57 to 64 were were reporting that they were sexually active over the past year, about half in the next age group, and still about a quarter in those aged 75 to 85 years old. However, only 40% of males and 20% of females aged 50 or older had discussed sex with a healthcare provider. And I think, we can all reflect on our own panels where we probably would have liked to ask patients a little bit more about their sexual health, during our visits, but it often does get either pushed to the side or truncated for whatever other reason. But I've certainly been surprised in my own visits with patients when we do have the opportunity to ask how open sometimes they are in talking about some of these issues and how pressing some of their concerns are. And so what really drives this low prevalence of discussion about sexual health? Well, one of the main drivers is the underestimation of risk due to age. And that's kind of a bias that we as providers may have. It's important to remember that erectile dysfunction medications have allowed many men to remain sexually active later in life than they may have previously been able to. Patients also underestimate their own risk. There's generally less knowledge about HIV in the older population. We also see continued substance use, which affects barrier contraception adherence, which we saw is felt to be one of the main drivers in some of these trends in prevalence and incidence of HIV infections in older adults. On the clinical side, HIV infection can present as, sort of non-specifically and can often be mistaken for cancer when we look at patients who are presenting with fever, fatigue, weight loss, and malaise. And as geriatricians, obviously we're attuned more to the role that HIV can play in the development of cognitive impairments, but it is also important to make sure that in our evaluations, we do consider HIV. And what all this means in sort of summation is that older patients are more likely to be diagnosed later in a disease course, which means they're starting treatment later, which means there's more damage to their immune system as well. Current screening recommendations from the CDC sort of point towards a risk-based screening for anyone over the age of the general population over the age of 65 years old. For anyone under the age of 65, so that group of adults between 50 and 65, there's the recommendation for a once-in-a-lifetime HIV test. But the goal is to move away from risk-based testing for our population, the older adult population. We know the data shows that it's less stigmatizing, especially with sexual minorities who face challenges in having discussions of risk behavior with their providers. Older sexual minorities face the additional challenge of the stigma of age as well. Briefly taking a look at the cost effectiveness of universal screening versus risk-based testing. A lot of it uses old quality adjusted life year metrics of $50,000 per healthy life year, which is felt to be somewhat outdated. But using that data, it did suggest that universal screening is justified in any population where the threshold of undiagnosed HIV prevalence is greater than 0.1%. There was a study done out of the VA in 2009, a universal screening study, which showed new HIV diagnosis in the general population of 0.14% during that period of time versus 0.46% when they were using risk-based testing prior to the implementation of that. If you look at the population in the VA greater than 65 years old as a whole, it did not cross that 0.1% threshold. However, among Black veterans in that population, in the age group of 65 to 74 years old, the prevalence was 0.16%. And for those greater than 75, it was just at the cusp at 0.09%. There were a couple studies done that sort of updated that quality metric to $100,000 and then sort of accounted for improvements in antiretroviral therapy and different test and treat strategies. And it found that the standard routine testing, taken for all individuals over the age of 65 was cost effective in many different settings. But sort of alluding to that slide, we know the epidemiology of HIV infections in the United States is very disparate, and Black and Hispanic people account for a higher proportion of new HIV diagnosis and people living with HIV compared to other races and ethnicities. And a lot of this is driven by persistent racism, HIV-related stigma, homophobia, poverty, and other barriers to healthcare. which continue to drive these disparities. So this data is from 2019, showing incident infections in the United States across different racial and ethnic groups, with Blacks being disproportionately affected, followed by Hispanic and Latino patients. So knowing how many people are living with HIV both across the US and globally, I'd like to take a look and see how far we've come with regard to life expectancy. So going back to those early slides from the 80s and 90s, knowing that AIDS was meant a prognosis most likely of months to years if you were lucky. Fortunately, we're in a much different place right now. JAMA actually had a large study using about 400,000 controls and about 40,000 patients with HIV through the Kaiser network. And they wanted to take a look and see the effect that antiretroviral therapy was having on aging and survival, as well as morbidity. The takeaway is that there's a 9.1 year difference in overall life expectancy from 2011 to 2016. But if you take for patients who are with HIV infection versus without, but if you then take that data a little bit more granularly, and if you have patients who do have HIV and were started on antiretroviral therapy with high CD4 cell counts, that difference shrinks to 6.8 years overall mortality difference. However, despite that, they did find a large and persistent difference in comorbidity-free years, with individuals with HIV infection living 16.3 fewer healthy years than uninfected adults. If you take into that account who had started antiretroviral therapy at high CD4 cell counts, this difference shrinks slightly to 9.5 years, with improvements across all comorbidities. So the results basically suggest that individuals with HIV infection who started antiretroviral therapy at high CD4 cell counts may receive or reach a very similar lifespan as uninfected adults, but there needs to be greater attention paid to the prevention of comorbidities among individuals with HIV infection. A large data set of US commercially insured Medicare and Medicaid patients showed that hypertension, hyperlipidemia, and endocrinopathies were the most common non-AIDS morbidities that we see in persons living with HIV. And it's felt that there's obviously various reasons which could contribute to this, but higher rates of substance use in the population, persistent immune activation, as well as antiretroviral therapy side effects are thought to play a major role. We know through these data that multimorbidity is more common among adults with HIV, and that prevalence increases with age. And that factors associated with increased risk of multimorbidity include nadirs of CD4s less than 200, older age, male sex, and prolonged exposure to antiretroviral therapy. And to sort of better quantify this increase in multimorbidity, the Journal of Clinical Infectious Disease performed a case control study that showed the prevalence of multimorbid patients with HIV was comparable to a control group, which was approximately 10 years older. Looking at some of the bone disorders which are common in persons living with HIV, a meta-analysis was done. It was approximately 20 cross-sectional studies measuring bone mineral density, about 900 patients with HIV. 2/3 of them had reduced bone mineral density, and about 15% of them met the criteria for osteoporosis, which was greater than 3 times the background rate of both of those in the HIV uninfected controls. There are multiple reasons why HIV can lead to bone disease. The ones sort of directly related to toxicity include chronic T-cell activation, increased production of pro-inflammatory cytokines, which can enhance osteoclast activity. The rank ligand protein can induce bone loss. We know that the osteoprotegerin molecule counteracts its activity, and in HIV, this synchrony is made all wacky, and essentially you see accelerated bone loss through increased rank ligand expression. HIV proteins can also decrease bone formation by promoting osteoblast apoptosis. So those are more of the direct mechanisms. However, more commonly, you're seeing systemic inflammation, circulating cytokines, and then associated risk factors, which do play a major role as well, including opportunistic infections, neoplasms, medication side effects. You see lower vitamin D levels, concurrent hepatitis C infections, side effects from antiretroviral therapy, and higher rates of chronic opioid use, which can lead to hypogonadism as well. And so there are some best practice guidelines which recommend screening for osteoporosis in women with HIV once postmenopausal and men starting at the age of 50 years old. Significant too in this population are neuropsych changes, including mild to moderate cognitive impairments, as well as depression. So this data was out of San Francisco as well, where about half of the patients treated through the UCSF Silver Project were experiencing mild to moderate cognitive impairments, and about a quarter had depression. And so they have a multimodal approach, which includes geriatric care, mental health care, HIV care, primary care, pharmacy involvement. So a large multidisciplinary team to help provide the best and most supportive care for these patients. And there's definitely literature out there now looking at how significantly improved antiretroviral therapy has become, and sort of simpler regimens, the role of infectious disease versus primary care and geriatrics, and continuing to manage these patients as they age because of the multimorbidity, because of how complex these patients are becoming from a non-HIV perspective. So it's an ongoing area where it should be interesting to see, where patients, the best care that we can provide moving forward. We alluded to the fact that geriatric syndromes were also more common in patients living with HIV. Looking at a study out of the Journal of Acquired Infectious Disease, it was a smaller study, but it was cross-sectional HIV-infected adults age 50 years and older who had undetectable viral loads on antiretroviral therapy. And they found that pre-frailty was prevalent in over half the participants, as well as roughly 50% prevalence as well of difficulties with IADLs and cognitive impairment. They found that non-white race, low CD4 count, increasing number of comorbidities were associated with these higher risks of geriatric symptoms. And they did see that there was a protective effect from the exposure to older antiretrovirals, which was inconclusive, but felt to be secondary to potentially a survivor effect of just having patients who did survive through those older periods, and maybe we just had a more robust baseline. Looking at falls in this population, there are a lot of reasons why patients with HIV might be at a higher risk for falls, including polypharmacy, peripheral neuropathy related to HIV, as well as the treatments, increased risk of osteoporosis. However, the literature was fairly inconclusive with regard to fall risk in patients with HIV versus those without. One of the studies that I had looked at was a retrospective review of about 500 people. They noted similar fall rates among HIV-infected and unaffected participants. They felt that a lot of the similarity was explained by a high baseline prevalence of imbalanced symptoms in both groups. Going a little bit more into the polypharmacy, again, in the aging population, there's a lot of reasons why polypharmacy should be a problem. Actually, Journal of Acquired Immunodeficiency Syndrome showed that the data suggests more favorable adherence to antiretroviral therapy regimens in older adult patients, although there are a lot of factors that we can see which we need to kind of be cognizant of that can affect this, including vision loss, cognitive impairments, which we know are very prevalent, limitations in health literacy, complex regimens, which thankfully are being, from the HIV side, simplified. Medication costs, certainly, concurrent depression, and then also patients' own decreased expectations of their health status. So in the next couple slides, I want to talk about aging with HIV and some of the research behind the basic sciences in it. So, taking a look at geroscience, studying the genetic, molecular, and cellular mechanisms that explain aging as a major risk factor and driver of chronic disease. A lot of the hallmarks of aging are felt to be dysregulated, especially in patients living with HIV, though it's unclear what effect the virus has and what effect its therapy have on the aging process. There's actually a large study out of the Lancet that was published most recently. I think the most recent sort of iteration of it was March of this year, and it's on aging with HIV and a lot of the different scientific, socioeconomic, factors that are sort of really important as patients move along the aging spectrum. They did a really great look into some of the biochemical mechanisms that are known to drive age-related conditions and how they apply to HIV and how HIV can affect them. So they took a look at things like cellular senescence, macromolecular damage, epigenetic changes, cellular inflammation, and stem cell exhaustion. For the sake of brevity, I'm going to briefly just go into a couple of the ways that they were exploring how macromolecular damage and HIV can be related. But I do encourage you to read the series. It's a really interesting and well written, well laid out way to learn a lot more about how the aging research in HIV are being explored. So within the realm of macromolecular damage, one of the areas where there's a lot of ongoing research is in telomere attrition. And noting that shorter telomere length has been positively correlated with age in most tissues, that they've documented shorter telomere length in blood cells of people living with HIV, as well as in the lung epithelia, compared to controls, that we know that shorter telomere length is associated with increased cardiovascular risk, but really exploring whether these declines disproportionately increase the risk of disease, its onset, its severity, and multimorbidity in patients with HIV. Taking a look at DNA damage and repair mechanisms, there's the deficiency in DNA damage response in lately infected cells from HIV. We also know that exposure to reverse transcriptase inhibitors can cause deficiencies in DNA damage response, as well as long-term HIV-related psychosocial stressors, including sort of glucocorticoid stimulation, adrenergic signaling, increased oxidative stress and inflammation, and really taking a look at whether the relation or what the relationship is between genomic instability and these age-related outcomes in people living with HIV. And lastly, as an example, we'll talk about loss of proteostasis and within the realm of macromolecular damage. So noting that protein homeostasis is maintained by a couple different protein clearance mechanisms, that HIV and other viral proteins can disrupt the autophagy process in certain cells, including neuroglia. We see an increase in HIV-associated neurocognitive disorders despite adherence to treatment. And there's this proposed mechanism via chaperone-mediated autophagy that prematurely degrades neurons, leading to neurodegeneration. And since I'm not a basic scientist, we'll leave it at that, but it really is fascinating to read about and to learn about in our field. But I think I'd like to move away from the basic science perspective and kind of evaluate more the clinical phenotype that some of these changes are bringing about. So the clinical phenotype in persons living with HIV has been described as sort of a combination of host and environmental factors, from impaired immune homeostasis leading to changes in intestinal mucosa, persistent systemic inflammation, tissue fibrosis, and disrupted neoplastic surveillance mechanisms. And looking at that, a lot of the goals, a lot of the research is into, can we change how aging with HIV looks, knowing that there are these underlying changes to telomeres, proteasome homeostasis, and DNA damage repair. So sort of another big area where a lot of the aging research in the HIV population is going is through epigenetics. So how our behaviors and our environment can cause changes that affect the way our genes work. And so unlike some of the genetic changes, epigenetic changes are reversible, which is why it's important to study them and learn about them and how we can, best help our patients. One of the studies we had looked at saw that the epigenetic age, so using markers of DNA methylation, histone modifications, and RNA coding, differed significantly between people living with HIV and those without, roughly 5 to 7 years. It was reduced. That epigenetic age difference was reduced in patients who had been receiving antiretroviral therapy. And there are a lot of modifiable risk factors for aging, which they felt could delay the aging process, as well as increase health span, which is those healthy years that are really important. And we saw such a large discrepancy before in that large JAMA study. So lifestyle changes that can be made, including cessation of alcohol, cessation of smoking, which is known to have deleterious effects on DNA methylation, exercise, which has been associated with increased telomere length, improvements of sleep, pharmacologic interventions, and sort of adaptations of aging models. So they noted the successful aging model, which was biopsychosocial and really incorporated a stronger self concept of cognition, perception of social relationships, emotional regulation, and coping skills. Also very important because of the prevalence of depression, underlying depression in the persons living with HIV over the age of 50 years old, and the sort of effect that self-perceptions of health can have on wellness and health outcomes too. So there are several models that are being put out to best explain aging with HIV and sort of how to use modifiable risk factors, or modifiable factors rather, that can help counteract the aging with HIV process. So again, these two are out of the most recent edition of the Lancet Aging with HIV series. This one, the Cascade model, noting sort of total organ physiologic function as represented in the graph by the size of the pool declining over the life course as a result of exposure to stressors. So that could be, any sort of health stressor, environmental stressor, sort of the whole biopsychosocial realm. And then also, an increase in this multimorbid environment that we see as people living with HIV age. So sort of seeing that these gero drivers, as they're termed, can negatively affect this process, while protectors, the things we kind of discussed in the epigenetics slide, can be used to attenuate that. And so the descending water pools decrease in size as the sort of homeostatic levels, or the capacity of our organ functions and reserve, becomes diminished in response to these chronic life, sort of cumulative life and history stressors. And another model that they had put forth is this organ crosstalk model. And it was a little more based on the deposition of sort of senescent cells. So the takeaway is that these HIV and age-related declines in reserve and capacities and stressors result in a loss of organ crosstalk and sort of organic homeostasis. And the senescent phenotypes of cells and distal organs, so deposition of these in liver, kidneys, lungs, sort of these chronic comorbidities that we know are more prevalent in people living with HIV, negatively affect the homeostatic environment that sort of promotes resilience and health. But again, heavily based off this idea of gero drivers and geroprotectors in biological aging, noting that a lot of the research that has to be done really is in trying to better understand specifically how those processes that we've been talking about imprint onto this model. And sort of in summary, I think, the main takeaway points here are, as geriatricians, it's really important because older adults are living with HIV in significant numbers. Their risk is often underappreciated by both providers as well as patients. Sexual minorities continue to face additional challenges in discussions regarding risks with providers, and this is only exacerbated by age. Many common comorbidities that we see in the general population are only more common in persons living with HIV. That integrated care delivery models can help provide comprehensive HIV and geriatric care. And that by screening for and diagnosing and treating HIV in our older adult population, we're helping our patients, as well as ensuring active and exciting areas of research continue to advance our understanding of how aging and HIV are related. Just a quick list of the references, and then plenty of time for questions and commentary.
Thank you so much, Drew. If anyone has questions, feel free to unmute and ask them. And if for some reason you can't, you can type them into the chat.
Hi, Drew. This is Tiffany, one of the new fellows. Hope everyone can hear me okay. Thanks for your talk. It was really cool. I'm curious if you happen to look into prevalence of PrEP use in older adults, since the prevalence is so high.
Yeah, no, it is fascinating. I didn't actually look into that. I should have, but no, I didn't. Sort of didn't organically come up in my exploration of all the literature. But I do think it's really interesting, and I think there's probably a great role for it. Yeah.
Hey, Drew, Wayne McCormick here. You may have mentioned this, and I wasn't paying attention at some point, but how are you defining multimorbidity? And has it got a different flavor among HIV older individuals than it does in our, senior care clinic population of 80-year-olds?
I think it was pretty similar. I think that the standard definition had been, greater than 2 or 3 sort of concomitant conditions. The Medicare data showed that hypertension, hyperlipidemia, and diabetes were essentially the most prominent comorbid conditions. So I think it's probably fairly similar to, the general population that we would see in senior care clinic.
I'm not sure if you can see the chat, but it looks like Elizabeth Phelan is wondering about the source of the recommendation for osteoporosis screening.
I can definitely find that. I just have to go through the references in there. Yeah. So I'll message you that, Elizabeth.
Yeah, thanks, Drew. And just to build out on what you were saying earlier about falls, we do, and our fellows, I'm sure you may have had patients that you saw with me yourself. We do see quite a few people referred to us who have HIV. And my impression is that there is a lot of peripheral neuropathy. There's also a lot of medication use for treatment of the same that probably contributes to their fall risk. But similar to other people who have multimorbidity, who do come to see us, at an earlier age, they do tend to be, in their 50s and early 60s. I don't know if Jenny's on, if she has anything more she wanted to add about that, but we definitely, it's definitely a phenomenon. Hillary List, a number of years ago, wanted us to do some in-service with their providers about falls, and I'm not sure we ever did that, but they themselves, HIV focused providers and adult medicine clinic and our other clinics at Harborview have been doing, I think, a really great job, getting that on their radar and referring people for preventive measures. But the osteoporosis piece is new to me. So that would be a game changer in terms of the recommendations we're making, even in these people at age 50, as you said, with males. So
Yeah,
would love to see the follow-up reference on that, because we can integrate that into our teaching in the clinic. Thanks.
Elizabeth, this is Kay. The osteoporosis, generally, especially if you end up seeing them like within their in their 70s, this usually ends up being severe. And that's a combination of typically what they're on for their medications, as well as the HIV process in and of itself. So I think that recommendation to screen earlier makes total sense.
Yeah. And as I said, most of the people we're seeing with HIV are not in their 70s. They're in their 50s and 60s. So I think it will be really important for us to integrate that into our care.
Yeah.
But we will be seeing them, based off the most recent data and how great it is that life expectancy has gone so far. I think we will be seeing more and more patients through their 60s, 70s, and 80s. Anything else?
So these results seem to suggest to me that if we're going to use an age cutoff for enrollment in a geriatrics primary care clinic or specialty clinic, that perhaps using an adjusted age cutoff for persons with HIV to be more inclusive of this population would be useful to capture these folks at a time where they could perhaps benefit most from this interdisciplinary function-oriented approach that we often use.
Yeah, I think so. And I don't think that there was any definitive consensus about what would, where we would start considering someone to be, aside from the traditional definitions of geriatric versus not, or when they might be more applicable to like a senior care setting or the geriatrics clinic, for instance, at the VA. But it does seem to suggest, or the literature seems to suggest, that when we're discussing older adults in general, that age cutoff for HIV patients is, roughly looking at 10 years younger, 15 years younger as what's considered to be an older adult.
Since it seems like we have a few minutes, I was wondering if Wayne, if he's available to unmute, can share a little bit about his experience. He has special interest and has a lot of clinical experience caring for people with HIV and AIDS at Bailey Boucher House, and was in, the founding medical director of that. Maybe you can just say what that was and what that experience was. And then you cared for older patients in Madison Clinic, and then eventually ended up just seeing some of those folks in senior care clinic. I was just wondering if you can kind of give that perspective over the years of how things have changed and any pearls you want to share.
Well, sure. I don't know how many additional pearls I have more than Drew just gave us a bunch of, but I was kind of thinking about that. It was a walk down memory lane as Drew was talking. During the 80s and 90s, Bailey Boucher House was basically a hospice. 1 or 2 people died every day. There was remarkable turnover. And it's just a 35-bed skilled nursing facility. It's not that big, yet the death rate was pretty rapid. And these days, in the second half of the 90s, and now the first couple of decades past the millennium, Bailey is kind of a hybrid facility. Still has the strong hospice skill and interdisciplinary approach. Currently, I was just there day before yesterday, and about 3/4 of the people there have HIV. The other quarter have some other life-ending illness like Huntington's disease, Lou Gehrig's disease, etc. Metastatic cancer. Among the other 3/4 with HIV, though, that's the least of their problems. It's the metastatic lung cancer and HIV, or maybe the ALS and HIV, etc. And it's interesting, a lady who just died a few hours ago, lovely person who had 3 decades history with HIV, but had pretty advanced COPD and a long history of rather severe impacting schizophrenia. She died this morning, mostly of her COPD, but she was pretty frail beyond what another 62-year-old with COPD should look like. So the advanced frailty, this chronic inflammation of long-term HIV infection, even if your viral load's suppressed to undetectable, it's not good for you to have HIV for 30 years and have that chronic inflammation going on. But in any case, I also ran into a day health client Tuesday morning, a guy named Bob. He's 84. And I started taking care of him at Bailey Boucher in 1994 when he was admitted with CNS tuberculosis and HIV dementia. He was mute and bedbound. That was in 1990, early 90s. He's still around. So against all odds, this guy is still here and actually doing pretty good. So it's remarkable how some people just seem undaunted with their long-term HIV infection. Anyway, thanks a lot, Drew, for this morning. It's great hearing from you.
Thanks, Drew. It looks like there's one more question from Elizabeth Phelan.
Yeah, Liz, I don't actually know. Oh, perfect. Thanks, Lauren. Yeah, so the Silver Project at UCSF is an example of that, of sort of concurrent HIV and geriatrics care. I don't know if there's any literature about how effective that is, or even what outcomes you would necessarily measure it versus a more traditional or a different style of co-management. But certainly, yes, there are programs in the country that are doing that.
And a good person to look for, Elizabeth, is Meredith Green. She spells her name with an E on the end, so Green. Meredith is a very important scientist and clinician doing HIV care down in San Francisco. They've got a really nice bunch of people working on HIV and aging in San Francisco.
I'll add, if anyone's interested, that sort of series I referenced from the San Francisco Chronicle, it's called The Last Men Standing, and they actually have an hour-long sort of movie documentary feature on it too. If anyone's interested, highly recommended.
Great. Well, I don't see any more questions popping up in the chat. Thank you so much for this talk, and for answering all the questions. And thanks everyone for joining and for the great discussion. So I hope you all have a wonderful weekend, and we'll see you next Friday again for conference.
Thank you all.
Thank you.
Thanks, Drew. Bye, everyone.